fixation. As we know that proximal humerus fractures has a B-model peak of incidence. Usually it's happen in young active people, but also in elderly it becomes the third most common fractures. Many surgeons consider proximal humerus fractures is a forgiving fractures. So the options may vary from conservative with the slings or internal fixation. You can do with wires, plate and screws, nails, even arthroplasty. There are factors that we need to consider before deciding what kind of treatment suitable for our patient. Most important are bone quality, comorbidities of the patient, and functional demand. The other important factor that we need to concern is about the vascularity of the humeral head. The most common classification that we use for defining proximal humeral fractures is a near classification, which is divide the proximal humerus into four parts, which is humeral head, lesser tuberosity, greater tuberosity, and the shaft. We will classify them as a separate part if there are 1 centimeter displacement, 45-degree angulation, or excessive rotation. However, if we try to do a near classification, there is a poor inter and intra-observer reliability, especially when we use X-ray only. So it is considered will be more reliable if we have a CT scan to have a better understanding about the fractures pattern. If we talk about vascularity of the proximal humerus, it is considered that the main blood supply of the humeral head it comes from the posterior humeral circumflex artery. And Hertel defined that medial calcar is a very important part that we need to pay attention. If we have a fractures of the medial calcar or comminution, the metaphysis, there will be high chance to have a AVN of the proximal humerus. However, it doesn't mean that if we have a positive Hertel criteria, we don't do fixation, because Bastian in GSS 2008 already have a study that 80% of patients with ischemic head, if we classify based on Hertel criteria, then he do fixation. At the end, there is a little number of patients that has a fast head collapse. It means that it's still worth it to do fixation. So what is my strategy when I have a proximal humerus fractures? First, we need to know our enemy. CT scan is very important. When we have a X-ray of the proximal humerus fractures, like in the slide, we tend to consider this is a benign fractures. This is a simple fractures, non-displaced. If we want to do ORIF, it will be easy. However, if we take a look at the CT scan, we can find that the fracture pattern split the head. So this is not a good candidate for internal fixation. In proximal humerus fractures, I would like to have fixation as my first choice. We can do with percutaneous pinning, plate screw with locking or non-locking, or nail. However, we need to think about complication. There are non-union, malunion, hardware problems, the screw may tear out, or AVN. When I do fixation, I will use a deltopectoral approach. I use this one because this is a very extensile. We can do good exposure, and what we need to be concerned is where we put our retractor, because the blood supply comes from the medial part. I try to avoid putting Hohmann retractor on the medial side. I would like to use the Army Navy or Ragnell retractor, and for the lateral side I try to also avoid putting Hohmann retractor too deep because it will injure the axillary nerve. Second thing is where we need to aim the screws. CT scan studies of the proximal humerus show that in the anterior and the superior part of the humeral head, the bone density is less than the posterior and the central. Therefore, when I put my screw, I always aim the screws to the posterior or the central. We need to restore the normal anatomy parameter. We need to think what are the normal parameter. First thing is the head summit should be higher than the GT. If we malreduce it, the GT is higher than the head, it will impinge. It will make abduction of the humerus block. Second thing is we need to restore the CCD or the neck humeral head angle. It should be about 135 degree. The most common problem after we do fixation is we will have a varus collapse. This is because we have a very strong muscle pull in the proximal humerus because of the strong pull of the rotator cuff. We have to encounter this problem. So how can we avoid the varus collapse? Remember, when we have a proximal humerus fractures, the proximal humerus, usually the head is so spongy and the shaft of the humerus impacted to the humeral head. So after we have a good reduction, we will always have a big void in the humeral head. So this is a problem. If we just leave it like that, our screw purchase will not adequate and there will be a varus collapse. So how can I prevent varus collapse? There are several tips and tricks. I use impaction grafting. You can take from the iliac crest or use a fibular strut, or in very rare case, sometimes we need to use a double plate. The other thing we need to concern if when we do reduction, we better use a suture tack to the tendon. If we use a hard instrument, the fracture fragment usually is very thin and it will be comminuted or more fracture if we try to pull with a hard instrument. So I recommend use a suture tack to the tendon and we can pull the fracture fragment. After have the reduction, we will need to incorporate those suture tack to the plate. In this way, we will transfer the pulling force of the tendon directly to the plate, not only to the head. So this is the way how I prevent the varus collapse. In this case, when the rotator cuff contract, it will pull the whole humeral head and the shaft together as a one block. Another proximal humerus fractures that we always encounter is about GT fracture. This looks benign, but sometimes it's very tricky. I tend to classify it into two types. One is shear type, the second is avulsion type. In shear type, we will have a large one-piece fragment. In this kind of fractures, we can do fixation whether with screws or plate because we have a big enough fracture fragment. But sometimes we will encounter a small avulsion type or comminution type of GT fractures. In this case, if we put screws, the fracture become more comminuted. So how we can fix it? I suggest we can use a transosseous sutures, whether you use a suture anchors, but this one will be will be expensive, or you can use the simplest way with the transosseous sutures. And post-op, I always immobilize my patient in a sling for 2 or 3 weeks and start with pendulum exercise and shoulder shrug to avoid muscle stiffness. And after 4 weeks, I will start my patient with the table slide exercise. In summary, I always try to preserve the head. We need to do anatomic restoration of the proximal humerus, and rotator cuff is the key to have a good reduction and prevent varus collapse. It is better to do acute fixation than late fixation, and we need to start early and protected range of motion exercise. Thank you.